Hello friends, welcome back to my channel with a new video. And this time I have taken the subject of weaning, and considering the span of the talk or the subject, again I have divided into three short videos. This is a particular talk by the heading of Fundamentals of Assessing Readiness for Extubation, was deliberated by me during the 6th International Conference of Nepali Society of Critical Care Medicine in association with Critical Care Nursing Association in the month of November last year. So let's start. So this is a beautiful Tribhuvan International Airport. And coming to the nomenclature, as we all know, if we actually embark upon this particular subject, uh, we should be well versed with a definitive definition of what is weaning. So, weaning is gradual process of improving the strength to load ratio of respiratory system to enable spontaneous respiration. And liberation is a rapid removal of burden which is no longer necessary. So, there is a definitive difference between these two terminologies which were once upon a time used interchangeably, but now we are very clear what do we mean by weaning and what is liberation. So, weaning starts when the clinician decides that the patient may tolerate a reduction of mechanical support. Again, traditionally, we were taught as to when to think of weaning is at the moment, at the time when we intubate the patient. So in other words, it is to be decided as early as possible. And definitely, there is readiness testing with the objective clinical criteria. I'm sorry. And it will include the methods used for stepwise reduction in the level of support and readiness testing of the ability of the patient to sustain spontaneous breath. So, as we know, our ties with Nepal are very good, and so is the case with me. I have very good friend of mine in Nepal as a very senior critical care specialist. I was fortunate to meet the legend in the field of mechanical ventilation, Dr. Brochard, during our National Critical Care Conference, which was held in 2023 at a beautiful city of Indore. And some of my literature is also taken from the textbook written by Martin Tobin. And as you could see, that uh, Professor Brochard again has a tremendous and immense contribution in the field of mechanical ventilation, especially the weaning. And there are few articles and trials as far as the understanding of the pathology of weaning is concerned, which was published in American Review of Respiratory Diseases by Dr. Brochard in 1988. And of course, as I said, this is the textbook by Dr. Martin Tobin. So let us start with a prototype case. 35-year-old lady, day 5 in ICU following a laparotomy for a perforated duodenal ulcer with peritonitis. On examination, she is sedated with fentanyl with a dose of about 50 micrograms per hour and a RAS score of -4. She has warm peripheries. The MAP is around 75 on an infusion of noradre, which is not a very high dose, as you could see. And of course, she is on ventilation with a control mode PRVC with a good saturation on FiO2 of only 30% with PEEP of 5. Urine output is good and labs fairly seems to be okay. So, what do you think? Should we wean this patient if the patient other parameters look okay? So, let us dwell into that. So, as we know that the weaning has two arms, that you have to evaluate the objective criteria, and of course the weaning process starts with decreasing the support. From the full support you come to spontaneous breathing trial, and then you have a gradual decrease in the support following discontinuation of mechanical ventilation, which will eventually decrease the morbidity and mortality, and of course the cost involved into the care of that particular patient. So first and foremost, the question comes is why to wean the patient from mechanical ventilation? Because when we know that weaning, the delayed weaning exposes the patients to unnecessary discomfort, impaired mobility, impaired speech and swallowing, increased risk of complication in the form of VAP or DVT or stress ulcerations and airway strictures. Of course, it has a bearing on increasing the mortality and of course the cost, as we discussed. So this was a AJRCCM paper way back in 2000, and it says that increase in the extubation delay time between the readiness day and the effective extubation, which will increase the mortality. The mortality was about 12% with no delay in extubation, as compared to 27% when the extubation was delayed. So time spent in weaning takes about 40 to 50% of the total duration of mechanical ventilation. So for an example, if your patient is ventilated for a total of 10 days, then the initial 5 days is the duration when the patient is on almost 80 to 100% of mechanical ventilation, and the remaining 5 days the patient is getting weaned off. So let us find and look at what are the various methods of weaning. So by and large there could be the spontaneous breathing trial, or decreasing the pressure support, and of course decreasing the ventilator parameters. So if you see that this particular patient has an endotracheal tube with a T-piece, and if the T-piece is successful, by this we mean that the patient's heart rate, the blood pressure, the respiratory rate, the saturations are okay or in the physiological limits, we may extubate the patient. But at the same time, if this particular T-piece trial is failed, then we need to go ahead and do the workup for weaning failure. And the classical duration of the T-piece varies anywhere from 30 minutes to maybe 2 hours. So this is a very classical duration during which the T-piece is given. And as we know that spontaneous breathing trial is effective, efficient, simple and safe method of weaning, and it only means that when the pressure support is of about 5, so it's a minimum pressure support or CPAP, then we may call it as SBT or spontaneous breathing trial. So there are few studies, the SBT studies, as you could see, and they compared whether the T-piece versus pressure support versus CPAP and the automated trial. This were whether any one of this was better, and there was no statistical significance. And these were the studies, one from NEJM, the another was also from NEJM, and you could see that the mechanical ventilation days, the complications like reintubations, the tracheostomy, or the prolonged mechanical ventilation, and the cost, as you could see when they compared the spontaneous breathing trial and the control group, it was shown that the spontaneous breathing trial had the lesser days as compared to control. There were lesser complications as compared to the control group, and of course the cost was less. So SBT was shown to be better also if the endotracheal tube diameter, which is less than 7 millimeter, the pressure support is better. So this were a few of the studies, the SBT studies, which we would discuss, and I think we will stop at this point in time, and we will discuss the weaning process further in my next videos. So that's all for now. Tata, bye bye.